He's also an assistant professor at the Barcelona Institute for Global Health. In this session, we have 7 presentations. Our first speaker will be Dr. Rina Kingsbury, who is a consultant microbiologist at the National Reference Laboratory within the National Tuberculosis Institute in India. Dr. Rina's talk will be followed by a presentation from Buleng Marokane, who is a project manager at the NHLS in South Africa. Dr. Tarak Shah will follow as our third speaker. He's a medical officer at FIND in India, and he focuses on TB diagnostics. Solomon Bandi from Kenya, who works at the National TB Reference Lab coordinating external quality assurance programs on TB, will follow as our fourth speaker. Our fifth speaker will be Del Safi, who's working with the National TB Program in Afghanistan as a TB technology advisor. Dr. Ogwamaka Chukwuogo, working for the KNCV TB Foundation in Nigeria as a project coordinator, will follow thereafter. And our last speaker will be Anita Bukes, who works as a laboratory advisor under CDC in Namibia, supporting Namibia Institute of Pathology within Ministry of Health structures. Please don't forget to type your questions as the session progresses. Thank you very much. We now go to the presentations.
Hello, this is Dr. Reena, a consultant microbiologist at National TB Institute, Bangalore, India, and I wish to state that I have no conflict of interest to report. I will be talking about the phased scale-up of external quality assurance for Xpert MTB RIF testing under National TB Elimination Program, India. India had introduced Xpert testing in the National TB Control Program in 2016, and since then, the number of Xpert machines as well as the testing has increased by 6 times. Currently, there are around 1,200 odd machines in the program. India already has a robust EQA program for sputum smear microscopy. Hence, in 2018, it was thought to have a similar program for Xpert as well, using the CDC's dry tube specimen technology. The major challenges routinely faced in providing quality expert results are the lack or poor adherence to standard operating procedures, improper storage and transport conditions of assay reagents, inadequate, poor or no maintenance of equipment, lack of limited or regular on-site supportive supervision, and limited training and mentoring facilities. The quality assurance program helps in avoiding false positive and false negative results. It has 3 components: internal quality control, external quality assessment, and the quality improvement. The proficiency testing procedure is an important component of the QA program, which helps to evaluate the performance of the lab technician, functionality of the Xpert machine. It also helps in verifying that the testing was done correctly and patient results were reported without any error. Hence, it was thought to have the quality assurance program for Xpert as well. So as a first step to initiate the quality assurance program, the capacity building of in-country staff in manufacturing proficiency testing panels was done using the CDC's dry tube specimen. Following this, the standardization of SOP to achieve 100% panel stability and consistency was achieved. Data collection, monitoring and analysis tools were developed. Panels were manufactured, packaged and transported to different laboratories. The communication to the sites about SOP turnaround time and reporting mechanism was also shared. Simultaneously, the states, NRLs and the CBNet laboratories were sensitized about the quality assurance program to be conducted by NTI. Now, this is an overview of the procedure and describes the preparation of the PT panels using the CDC's dry tube specimen technology or DTS. In brief, 5 midget cultures were taken and inactivated using the SR reagent provided by Cepheid for processing samples to be run on Xpert. Following the inactivation, the inactivation was verified by incubating these tubes. After confirming non-viability of cultures, aliquots were made in tubes and air-dried in biosafety cabinets. 10% of the panels were verified before dispatching them to the CBNet laboratories. Each CBNet laboratory would receive a PT package directly from NTI Bangalore and it contained 5 DTS tubes, the instruction guide about the QA program to the CBNAT lab technician, and job aid containing instructions for processing the PT sample. So far we have conducted 3 rounds of such PT exercises, and in phase 1, there were 41 sites, 199 sites in the second phase, and it increased to around 622 sites in the third phase. And we are in the process of enrolling for the fourth phase as well, which has initiated. So all sites performed well in the EQA panel, and in both first and second phase, most of the sites all the sites had obtained 100%. In the third phase, the 13 sites had scored less than 80%, which was unsatisfactory. And to know the root cause analysis was conducted by visiting the sites and interviewing the lab technicians. So this is the comparison of key procedures across the phases of implementation, where in first phase, we started off making the PT panel for around 50 PT panels were manufactured, which was exponentially increased to 725 in phase 3. Packaging and shipment was done site-wise, and in the third phase, the color coding for state-wise was introduced. Results submitted by different sites, where in the first phase, it was through email submission. Second phase, we had followed the Excel-based reporting. In phase 3, we had formulated an online Google spreadsheet were used. Time for analysis of results, this was done manually. We had taken 1 week for phase 1, and in phase 3, it had crossed more than 3 weeks for analysis alone. Completeness of the submitted data was very good in phase 1 and phase 2, whereas it was not so good in phase 3. So the problems encountered during the 3 phases, along with their mid-term corrections, are listed here. So to overcome the problem of incorrect postal address and to keep a track of receipt of the PT package at the CBNAT lab, a CBNAT EQA portal, it's a software which it was developed, and it will be used for the 4th phase. Structured automatic email generation for the portal directly to the site was also built into the software, so to diminish the gaps in dissemination of feedback report to the sites from the state. Unsatisfactory performance of CBNAT site in EQA would be analyzed by correlating the monthly monitoring data, and solutions would be given. And based on the experience of the 3 phases, the main recommendations for better implementation of EQA to the CBNAT laboratory would be to monitor the error rates, as there would be early signs of module or machine failure, and perform maintenance checks of their machine routinely. For the states, it would be to organize more number of refresher trainings and to intensify their monitoring and supervising activities. For the PT provider, that is NTI Bangalore, we would explore better methods for result collection, compilation, analysis, and release of results. So in conclusion, I would like to say that EQA for Xpert MTB-RIF can be implemented in high burden resource constrained settings, provided that in-country capacity is built for manufacturing PT panels, and the existing tiered monitoring infrastructure, which is already there for sputum microscopy, can be utilized for implementing the EQA for CBNAT. And EQA is very critical for monitoring quality of CBNAT testing and identifying non-conformities related to testing procedure. I would like to acknowledge Central TB Division, Ministry of Health and Family Welfare, Government of India for guidance and leadership, International Laboratory Branch, CDC Atlanta and CDC India for technical and financial assistance. Find my colleagues, Dr. Kishore Reddy and Dr. Vidyanidhi for their technical support. PATH for financial assistance, participating NRL, IRL state and the sites for their participation. Thank you.
Greetings, everyone. My name is Puleng Marokane. I work for the National Priority Program of the NHLS, which is National Health Laboratories Health of South Africa. So I just want to start by declaring that I have no conflict of interest to report. Today, I'm going to talk about South Africa's Xpert MTB-RIF Ultra EQA experience. Okay. Just to give you a bit of background to the South African Xpert MTB-RIF Ultra program, which was initiated early in 2011. The program is highly decentralized across 166 laboratories, which are comprising of 341 instruments of varying throughput. The implementation of the Xpert has improved South Africa's diagnostic capacity with over 17 million TB tests performed to date. All our systems are interfaced to the NHLS laboratory information system, enabling monitoring and evaluation of national program. In addition to this, we have a C360 remote monitoring software that is configured on each Xpert computer. And all our Xpert sites are registered to participate in a 3 times a year EQA program with Smart Spot Quality. Okay, we have participated in the Smart Spot Quality EQA program from year 2013, the aim of which is to monitor ongoing quality of testing services. The program has over 97% submissions and overall 100% pass rate of 90%. The EQA program uses dry culture spot technology, and it has an online quality assessment tool. So by March 2018, South Africa had transitioned from the Xpert MTB RIF G4 assay to Xpert MTB RIF Ultra assay due to its improved sensitivity. The first EQA panel of 2018 was performed using Ultra reagents. And on this slide here, I'm showing types of incorrect results that we normally see in the EQA program. So the first one is inadequate mixing of samples during processing. This can result in discordant MTB results. Sometimes failure to detect the rifampicin region, and also trace results can come into play. The second type of incorrect results is contamination resulting in discordant results and also sometimes trace results. Then we have your errors, invalids, and no results. So with transition to Ultra, we had to compare the performance of Ultra to G4 assay to identify if there was any improvements and new challenges with the new program. So we know from previous experience with G4 that our incorrect results were mostly related to inadequate sample mixing, where you will get a positive EQA sample that is detected, where you will get a positive EQA results detected as a negative. With Ultra though, data analysis indicates that there's challenges and improvements with trace reporting. As you will know, that trace is an additional results that come with the Ultra assay. Okay, turning our focus on the challenges indicating contamination. So the table that is on the slide here is comparing EQA results from the G4 assay to the Xpert Ultra assay, which we moved to in 2018. The next column is showing the panel content. And then you will see percentage incorrect results for the G4 assay ranged between 1% to about 3% on the G4 assay. And when we compared with the Ultra assay, we saw a notable increase in the percentage incorrect results. Based on our finding, percentage contamination was part of the results that were seen under the incorrect results category. And you'll see with G4 assay, the range was from 0.1% to about 0.7%. And then with the introduction of Ultra, we saw a notable increase in this category. So Xpert Ultra had about 1.2% increase in contamination of these EQA samples, 69% of which were related to trace. These are some of the examples on EQA samples that were contaminated. So the first one you see is expected results were MTB not detected, and then the site had detected it as trace. The second example, MTB not detected, and the site had detected it as RIF sensitive. The third one was a positive sample that was meant to be RIF resistance not detected, which is a sensitive, and the detected results was a resistant. So reasons for contamination were related sometimes to the contamination from the EQA samples themselves in the same batch, or contamination from the environment, the bench, or other routine samples. If we turn our attention to the challenges indicating inadequate mixing, so using the same table, percentage incorrect results related to inadequate mixing for G4 assay and Ultra assay, you will also see that there is a notable increase as well, 0.4% increase in inadequate mixing, 82% of which were related to trace results reporting. So an example here can be trace results reported on an already known positive sample. So if we send a site a RIF resistant sample and then they detect it as a trace. So the slides that I'm showing now is showing the triggered interventions that we implemented to address the concerns that were listed. So we had a dedicated Xpert MTB REEF technical team. We included GLP and contamination awareness programs in our training. We revised all our SOPs. We had ongoing training, ongoing monitoring through the use of the dashboards that are in place, monitoring positivity rates. And then also the EQA provider had added an additional EQA spot called Trace. This was to assist us in detecting contamination better. So in this trace spot, the expected results will be the detection of insertion sequences only. So if a lab was to detect the RPOB region, then that will be considered as a contamination. We also have ongoing laboratory surveys to gather information on whether current controls are beneficial for monitoring. The areas of focus for training were on sample preparation, advising the sites to work from clean to dirty, frequent changing of gloves. Okay, so just to touch on the ongoing ultra standardization surveys that we implemented in 2019. The first survey was performed across 21 laboratories in the month of September 2019. We had a mix of good performing sites and those that had reported contamination in previous EQA panels. 124 uninoculated and autoclaved EQA samples were distributed to be tested between routine work over a period of 3 days. So the instruction here was that the lab was to test the first sample on the first batch of the day, and then test the second sample with the last batch of routine work of the day. During this period, there was about 30,000 routine tests that were performed, 8% of which were positive, and then we also had a trace of about 2%. The EQA data analysis did not identify any contamination. However, when we further analyzed, looking at when the samples were tested, we noted that the samples were only exposed to about 5 MTB detected sample and 1 trace. So this means that we will need to further expand and redesign our survey, as no contamination of EQA samples were reported in all participating sites. So we are in the process of expanding and redesigning the survey to ensure that we maybe provide more samples to improve exposure. So in conclusion, the ultra test, as you know, is more sensitive as it identifies the different multi-copy amplification targets. So due to this increased sensitivity, it's very important now to improve stringency of techniques during preparation of samples. It's very important to emphasize good laboratory practice. Continuous monitoring across all programs is also critical to maintain quality and provide feedback on any potential issues. It's important also to know that where contamination has occurred, the higher the likelihood the contamination will be detected on ultra when compared to the G4 assay. So this means our SOPs and our training material should adequately address these areas of concern. I would like to acknowledge the following teams and groups that are mentioned on the slide. And thank you very much for listening.
Hello, I'm Dr. Tarak Shah, Medical Officer with Fine India. I have no conflict of interest to report. My topic for presentation is mentoring TB labs for improving and sustaining QMS implementation and ISO 15189 accreditation experiences from India. I'll be presenting on behalf of my colleagues from Fine and Central TB Division. Background. In 2016, out of a large network of more than 65 labs, only 2 TB laboratories in the NTP network were ISO 15189 accredited. In 2016-17, Fine, in collaboration with CTD, supported 11 TB laboratories to improve their quality management systems and achieve ISO 15189 accreditation from National Accreditation Board for Testing and Calibration Laboratories, that is NABL. These 11 sites, as seen on the picture on the right side, included 5 national reference laboratories, 5 intermediate reference laboratories, and 1 TB culture and DST laboratory. In the interventions, we had a preparatory phase of 6 to 9 months, that is for site selection, stakeholder sensitization, and initial site assessment. This was carried out in late 2016 and early 2017. This was followed by mentoring and implementation for a period of 5 to 7 months, and it included internal auditors and QMS training, mentoring through workshops, monthly on-site visits, off-site support. And guidance was provided to the sites to adhere to various clauses and sub-clauses of ISO 15189. This occurred in 2017. Then comes the application process, which was from 5 to 9 months, and support was provided to the sites for submission of application to NABL. This was followed by pre-assessment and assessment by NABL. This occurred in 2017 and 18. Sites achieved their enable accreditation for ISO 15189 and they continued quality improvement and maintained QMS. The sites got accredited from May 2017 and the last site to get accredited was in September 2018. And they continued their journey of quality improvement up to the stage when we carried out follow-up assessment of the sites. This follow-up assessment was to review progress, identify gaps, and measure quality improvement made since baseline assessment. Follow-up assessment was carried out from October 19 to February 20. Overall, mentoring support and continuous follow-up with the sites were the key to fast-tracking quality improvement. So the results are, all the 11 sites successfully achieved ISO 15189 enable accreditation. Below, we see the two graphs which are reflecting of the scores during initial assessment and follow-up assessment. These assessments were carried out using the same TB harmonized checklist developed by FINE using the SLIPTA model. This checklist covered all the 12 quality system essentials as seen in the pictures graphs here. When you look at the initial assessment and follow-up assessment, in the initial assessment, the labs already were good in the field of equipment, purchase and inventory, and information management. And it was good to note that they maintained it. Improvement was seen specifically in documentation, management review, organization and personnel, internal audits, client management, and customer service. Overall, 8 out of 11 sites, that is 72%, improved and sustained quality with total scores being more than 85%. The remaining sites scored between 75 to 85%. While implementation, there were some challenges. A few labs lagged in effectively implementing corrective action, occurrence management, management reviews, etc. Although they had improved scores in the follow-up assessment. Action plans were prepared for each site for rectifying the lacunae, which they have implemented. In these slides, we see the qualitative improvement at the sites which occurred during the mentoring process. Here you see an example of well-organized storage area following first expiry, first out approach. Dedicated refrigerators for storage of infectious samples were arranged for. Well-maintained patient sample collection facility was developed with separate waiting area, sample reception, and collection areas. Labs used this opportunity to rectify long-standing infrastructure issues, especially accommodation and environmental conditions. Example, separate eating and resting areas for staff, toilets for women especially, drinking water, personal storage were specifically developed to ensure that compliance was met for accommodation and environmental conditions. At many sites, workflow was reorganized to further improve safety, segregate clean and dirty areas. Here we see well-organized QMS documentation that is uniquely labeled, authorized, and access controlled. Detailed personal files got developed for each staff, including health records, and were maintained inside the lab. Competency assessment were introduced at all the sites as part of the trainings. Here we see master calibrators and in-house calibration being done. Mercury-based thermometers were replaced with digital thermometers in the lab. In-house calibration trainings were done to take care of temperature-sensitive equipment, which also led to reduced cost on maintenance of equipment. Detailed equipment files were developed. Backup equipment and backup labs too were identified. Here we see biomedical waste management for proper segregation and disposal being properly implemented. Safety equipment and fire safety was strictly adhered to. Safety audits were carried out for the first time and documented. Safety officers were designated. Fire safety drills were carried out for the staff. Emergency shower, eye wash stations were rechecked for their functionalities. Routine first aid boxes were introduced. Here we see quality control for autoclaves. Biological indicators were procured and are now being routinely used. Dedicated incubators 56 degrees centigrade for incubation of biological indicators were being procured and are being used now. Chemical indicators recordings were being strictly monitored and implemented. So overall, mentoring support through FINE helped the labs in fast-tracking their preparation and achieve ISO 15189 accreditation. Conclusions. These 11 sites are sustaining their status and are in the process of continual quality improvement. With commitment, motivation, monitoring, and handholding, it is possible to improve and sustain quality of laboratory services and ISO 15189 enable accreditation even in resource-constrained, high-burden country. ISO 15189 accreditation gives confidence to the program about quality, timeliness, and reliability of diagnostic results from these laboratories. 6 more labs have applied to NEBL and are awaiting accreditation. NTP, along with FIND, plans to further support another 30 labs for ISO 15189 accreditation in the next 3 years. I would like to acknowledge the funding support from the Global Fund project, Central TB Division, WHO, and CDC for their technical guidance and leadership, participating national reference laboratories, IRLs, TB culture and DST labs, their directors, head, microbiologists, and the staff for their active participation and achieving accreditation, state officials of the participating sites for supporting the sites to achieve accreditation, mentors who provided timely guidance to the sites, colleagues in FIND who pursued and persisted with the sites to achieve the goals of the project. Thank you. Here we see a picture of one of our first mentoring workshops held at RMRC Bhubaneswar. Thank you very much.
So this is on a pilot study on the implementation of a proficiency testing dry tube specimen production at the National Public Health Laboratory, which is the TB reference laboratory in Kenya. On the background for the National TB Lab, the journey started back in the 2014. This is when the National TB Reference Laboratory started receiving the panels from the CDC Atlanta on the Xpert EQA. And that had been going on. And since the lab and the country felt that we need to have 100% coverage of the panels, so we requested for the technology transfer from the CDC to enable the country have in a production of the panels. And this was initiated by the training of the staff to know and have the skills on the PT production. And this is what is described in this abstract. So on the readiness assessment, this was dearly to be done. And the lab was assessed in 2018 by the CDC, who came on the ground to see the preparedness of the lab, the quality and the safety. This was to ensure that the lab is ready, since the TB is aerosols, so to ensure that safety and the quality of the management assessment was done and a successful go-ahead was given, which was then planned. And in 2019, the staff were selected and training was done from the SRL Uganda, whereby a training on the production and management was done. Immediately, the implementation of the same started in June. And we here realized that in June 2019, a pilot, first pilot was done, and the enrollment of the 20 sites on PT production, which was done in, was initiated. And during that time, the SRL and the CDC mentors were on the ground to see the whole process and the quality and the readiness of the panels. That was successful, and the second pilot was also done in 2019, the same year in November, whereby more sites were enrolled on the same, and 50 facilities were enrolled on the PT which was produced. So that continued, and from the pilot which was done, then the panels were able to be sent to those sites, and a successful feedback was attained during that time. The general process on enrollment, this starts with the enrollment of 20 facilities, as I described in the first pilot. And during that time, the mentorship, there, the picture shows on how the online mentorship was done on the picture. Then during that time, the online training was done to enable the facilities relay the results online, as described on the next picture, which was then done on the validation participation of the facility. The participating facilities were able to relay the results to NTRL. Then evaluation on the same report generation was done, and results relayed back to the facilities. So this enables the whole process to take place within that period of time. The process of specimen production starts with the selection of the isolates from known or characterized strains. which means the required criteria. These isolates are ideally subcultured in the midget. So after culturing, they're given the required time, and once they're positive, visual checkup and ID confirmation is done. From there, we proceed to what we call the inactivation, whereby the isolates are inactivated in 80 to 85 degrees for 1 hour. This will enable the isolates be denatured to prevent the infection. And after that, we do performance of now the preparation, whereby the vortexing of mixing to break the colonies done to get homogeneous mixture. From that, during that time after inactivation, again, the same is cultured to see if there is any viable or organism which will grow. This is given a period of 84 days until the 84 days are over, to ensure that there is no growth within those given isolates. Then a pretest is done. This pretest enables you to select the best isolates, which will meet the cycle threshold of 16 to 23. And from there, now the validation of the best isolates is done. From the validation, then the panel preparation is done, whereby 1 ml of the prepared 0.1 ml of each isolates is dispensed into 4 ml gravels for the final panel production. The validation usually takes place whereby the given number of facilities or the enrolled sites. If you have a specific number of sites, then the 10% of the prepared panels are done to validate. This will then give the reference values for the results, since this is going to be relayed online. And the table below shows the validation summary or chart, which will give a guide to the final results expected from the sites. So upon doing that, then the panels are packed and distributed to the facilities. So this was done in that first pilot. This was the process which was done during that time. And then the results of the pilot is here described, whereby you can see the 20 facilities which were enrolled during the first pilot. The response was 100%. We are able to get a 20 facility will give the feedback. 16 of the sites were able to get the 100%, and the 3 sites scored a pass, but not below, but above 80%. And one of the facilities failed due to some reasons. On the second pilot, 50 facilities were enrolled, and we had a response of 48 facilities out of 50, and the 2 were not able to respond due to some reasons, in which 37 of the sites were able to score 100%, and unfortunately 4 of the sites failed, and this was also captured and kappa done on the same to see the root cause of the same. And as described in the chart below, we had some reasons for fail, like errors which are indicated, and usually this happens for some reasons. This is a comparison of the 2 pilots, whereby we can see there was an increased trend of the facilities which were participating during that time. And the response and the results are relayed online on the image of the on-site site, which was validated during that time. And the results ideally the results was relayed online. And during that period, there was some few gaps which were identified. As you can see, 11 facilities had issues of incompleteness. That's one of the reasons which maybe fails or leads to some errors within the results. And we also had some errors in the first pilot. We had 3, and 4 in the second pilot, as described earlier from the above image, that there are some errors which occur maybe due to power and some other reasons. So in conclusion, from the 2 pilots, the NTLR was able to demonstrate a competence in the PT production. This was demonstrated from the 2 pilots. And we consider to increase this program from the 50 sites to cover the whole country, whereby we have over 200 sites doing the Xpert analysis and the testing using the Xpert technology, and to cover the whole country, as we have more facilities doing the same within the country. So I wish to acknowledge the TB program, which was part of this work, and the National Public Health Laboratories, the CDC, that's the Kenya CDC and the CDC Atlanta, which were part of the leading team in this process, and the SRL Uganda for the successful pilot process. Thank you.
Hello, thank you very much for speaking my abstract for the oral presentation. Thank you very much. My name is Dilaka Safi. I'm a senior new technology advisor from Xpert project to support NTP Afghanistan. Thank you. And next slide, please. Yeah, my presentation title is Role of Gene Xpert Technology in Early Detection of Rifampicin-Resistant Tuberculosis in Afghanistan. The abstract number is 3934, and I introduced myself before. Thank you. And next slide, please. This picture shows our one Gene Xpert site in the province by the name of host provinces. NTP provide the Gene Xpert machine, PPA, kits, and also the cartridges and everything necessary for Gene Xpert like UPS printer by support of the USAID and another partner to hold our Gene Xpert site. Next slide, please. The introduction, so as you know, the implementation of TB, tuberculosis is a major health priority for the world and also for Afghanistan as well. So the multi-drug resistant patients or MDR patients ignore it, a challenge for the health system. So for this reason, Afghanistan, installed the Gene Xpert machine for detection of the MDR patient and ignore for the treatment, and those patients sent to the MDR ward for the treatment. In 2014, National TB Program Afghanistan introduced the first Gene Xpert machine in Afghanistan. In Kabul, in the capital city of Kabul, for detection of rifampicin-resistant patient. And after that, so this process year by year, so they implement this process to all 34 provinces of Afghanistan for detection of the MDR patient and TB patient. In 2019, 45 Gene Xpert machine installed in 45 health facility in 25 provinces by support of the NTP Challenge TB. Challenge TB is one of the projects by support of USAID and Global Fund. Next slide. So the intervention NTP developed the Gene Xpert and sample transportation guideline, and also translated by 3 languages, English, Dari, Pashto, and also assessment tool, and also the process, the sample process and sample performance poster and register. And also NTP conduct Gene Xpert training for 100 laboratory technicians and 25 provincial laboratory supervisor to use this Gene Xpert machine properly. And also NTP regular supply the cartridge to all Gene Xpert site, conduct the supervisory visit from the all Gene Xpert site, and also the technical team review the available surveillance data to identify the role of Gene Xpert in detection of rifampicin TB cases in the country. Next slide, please. Methodology, we are collected all this data. Now I want presented through the NTP tools. The NTP technical team reviewed the data and collected from 2017 to up to 2019. And also we use the standard NTP reporting tools. Next, please. So the result, if you see the result in 2017, 7,542 tests performed in 10 Gene Xpert sites in 10 provinces. And from that, 6,522 It means 86% test was MTB detected, and 279, 3.6% RR patient was detected. In 2019, when we expanded the machine, also we done the test more. So in 2019, 52,783 tests performed in 45 Xpert machine in 25 provinces, and we performed, and from that, 16,145, it means 30% of MTB cases detected, and also 486, 1% RR patient was detected in those Xpert site. And for your more information, I also had the table. This table guide you very well. Next slide, please. Our recommendation is by smoothness of implementation of Xpert, we successfully detected the TB and RR patients and put it on the treatment. We recommend to expand this technology to more sites or more provinces to bring easy access to detect the TB and RR patient in future. Thank you very much. If you have a question, my email address is, I write it here. Thank you very much.
Hello, everyone. My name is Ogwamaka Chukwogo from Nigeria. I have no conflict of interest to report. My presentation today is on overcoming barriers to Xpert organization in Nigeria, an analysis using the access concept. These are my co-authors. We all work for KNCV Tuberculosis Foundation Nigeria, and we're funded by the United States Agency for International Development. So a little background. With the adoption of Xpert machine by World Health Organization in 2010, Nigeria commenced the rollout plan in 2011. And by the end of 2019, 407 Xpert machines had been installed across the country. And this is with the aim of improving tuberculosis diagnosis, including the additional advantage of detecting rifampicin-resistant tuberculosis. Despite this number, only 59% of all TB cases in 2019 were tested using the Xpert machine. So there is still an enormous gap in optimizing utilization of Xpert. This study examined the barriers. What possible barriers could there be to Xpert optimization? And we propose approaches to overcome these barriers. And so we had a desk review of 2019 Xpert data across the country. We used a qualitative case study approach to generate data on Xpert human resources experiences in providing Xpert services across this Xpert sites. So using interview guides, in-depth interviews were conducted with 45 purposively selected Xpert human resources from sites that performed optimally. And this is an average of 240 tests monthly and above. So these sites, these 45 sites performed 240 tests and above. And we interviewed the Xpert human resources in the sites. And again, we also interviewed sites that performed suboptimally, talking about 150 tests monthly or less. And these were 39 sites. We engaged with the Xpert human resources in these sites as well. And then we found out, we asked questions around what affected their work and how they overcome whatever challenges that are posed in carrying out these services in both the optimally performing sites and the suboptimally performing sites. And the views of the Xpert human resources was triangulated with the views of 23 TB program managers through key informant interviews. All interviews were audio taped and transcribed. We use thematic content analysis guided by the Penchansky and Thomas Access framework to analyze data. And this framework has what we call availability, acceptability, affordability, and accessibility. It actually measures, the access framework measures the degree of fit between the user and the service. So when we talk about availability, it measures the degree of fit between what services are actually available and how easy it is for people who need the services to have those services. How aware are they of those services? Acceptability is just about social access. Affordability is financial access. And accessibility is physical access, being able to get to the location of service. And what were our results? What did we find? Most of the barriers we found out were around availability and accessibility barriers. So we found that there was a skewed distribution of available GeneXpert machine in country, where the urban areas had a concentration of GeneXpert machines, but the rural areas didn't. We also found that there were inadequate human resources to even man the expert sites. There was poor maintenance and frequent breakdown of machines. Common finding again is irregular power supply because the GeneXpert machines are dependent on power and can't run without power. They use cartridges to function, and so sometimes there are cartridge supply interruptions, and there's also low demand for GeneXpert testing. So looking at an optimization package, we try to match each barrier identified to an optimization package. So for skewed distribution, establishment of specimen transport mechanisms will help so that those areas that do not have adequate GeneXpert machines can still benefit. So the sputum samples are collected and transported to areas where there are expert machines and the results retrieved in good time. For inadequate human resources, we can leverage on ad hoc GeneXpert HR staff, and that's what we're doing in our project. Poor maintenance and frequent breakdown, we train super users so that this can help maintain GeneXpert machines and also carry out minor repairs in the absence of the certified team who have been given authority to maintain GeneXpert machines across the country. Installation of solar panels would help in solving the power issues. Also prompt replacement of power accessories. And for cartridge supply interruptions, strengthening the supply chain would help. Low demand for GeneXpert testing. Indeed, if there isn't demand generated for GeneXpert services, there will be no one to use the services. So demand creation through active TB case finding activities, both in the facilities and in the communities, is encouraged. And in conclusion, this study highlighted the complexities that influence realistic optimization of GeneXpert, but then again also mentioned the ways we can surmount these complexities. It is imperative that the design of GeneXpert optimization interventions integrates approaches to overcome potential constraints for effective TB control in Nigeria. Thanks very much for your time.
Good day. I'm Anita Beekes from Namibia, and I would like to thank the organizers for giving me this opportunity to share with you the Namibian experience of using MTB-RIF in mobile vans in Namibia. To start off, I would like to give you a little bit of background. Namibia has an estimated population of 2.5 million. The adult HIV prevalence is 12.6%, and the current TB case notification is 314 per 100,000, with regional differences, as indicated on the map. Khomas have the highest burden and Konini the lowest burden. Based on the DPS outcomes, the notification was 465 per 100,000. Estimated indicated that Namibia is also the 11th highest incident rate of TB in the world. Since 2017, Namibia introduced GeneXpert as the primary TB diagnostic test. Mobile Xpert MTB RIF testing was introduced by the TB Prevalence Survey to access harder to reach areas and increase testing coverage to at-risk populations. To give you a little bit of background on the survey population, for in-depth details on the survey population, please refer to poster named Results for Namibia's First TB National Disease Prevalence Survey 2017 to 2018. However, in brief, as part of the National Representative Population-Based TB Prevalence Survey, participants 15 years and older drawn from 68 clusters selected by the National Statistic Agency underwent symptom screening and chest X-rays. Participants were eligible for sputum collection and Xpert MTB RIF testing if they had an abnormal X-ray as well as TB symptoms. Participants which provided sputum were included in the survey if only one specimen was collected, even though national guidance required 2 at a time, one for Xpert testing and one for culture. The testing method. 4 mobile vans were utilized to install 8 4-module GeneXpert platforms, 2 per van. The power for the instruments were from the national power grid, but intermittently solar power and petrol generators were also used to provide power. A laboratory technologist in each van conducted testing. Sample checks for volume adequacy and suitability were done soon after collection. Some results. 29,525 participants were enrolled in the survey, and of these, 10,884 survey participants were eligible for sputum examination. 86.9 submitted at least one sputum specimen for examination, and 74% submitted 2 specimens. 11% submitted only the first specimen. Since healthy individuals from the general population were requested to provide sputum, it was sometimes difficult to produce sputum, and in some instances, no sputum were collected. Results from the field testing. 87% of the 9,462 participants that submitted sputums received a mobile Xpert MTB RIF test result within 48 hours or less. 1.3% tested positive for MTB, and this positivity translates into a final prevalence of bacteriologically confirmed pulmonary TB of 465.2 per 100,000. This have got a 95% confidence interval, and it is also in range with WHO estimates. 3.5 errors per 1,000 tests were recorded for all 8 instruments during the survey, and 66% of those were attributed to malfunctioning of air-conditioned systems in a single van. Lessons learned from the field. Let's start with equipment. During the survey, it was found that solar power were not sufficient to power equipment, and therefore the location of mobile vans were driven by the availability of the national grid outlets. Another challenge was caused by summer heat that caused instrument to overheat, and that's why the team had to revert to nighttime testing when it was cooler. The GX4 instruments capacity were also challenged by workload in some clusters. Moving to sample collection, some participants had difficulty to produce sputum, as we alluded earlier, and another challenge was the second specimen collected at a later time because we required spot mourning, but participants failed to bring back the second specimen, and we had to revert to spot within 2 hours of sputum collection. Due to safety requirements, sample preparation was done outside vents, but weather conditions were not always favorable for this activity. And lastly, data management. A special interface were needed to be written to connect various data systems to ensure or to cut out manual data entry. This also takes time for this activity to be perfect. Delay in results due to instrument breakdowns were also possible during the survey. In conclusion, Namibia's experience showed that Xpert MTB-REF testing in mobile vans was feasible, increased access, and it may be used for field-based screening. Trained operators, well-functioning vehicles, and quality samples is always necessary to ensure proper testing, and mobile testing allowed for 87% of participants to be tested and receive results within 48 hours, and 74% of participants to submit the 2 samples required by the national TB testing guidelines at that time. And lastly, I would acknowledge the contribution of the Ministry of Health and Social Service, Centre of Disease Control in Namibia, the Namibia Institute of Pathology, UN agencies, KNCV TB Foundation, and the Namibia Statistics Agency who made this intervention possible. I thank you.
Have questions from the audience, and I'm going to start addressing them. So the first question, which was partially answered in the chat, was made by Richard Anthony, and is addressed to Tarak Shah, but I think also Puleng can also give us her insight. So the question says, do you think it will be possible to develop a panel suitable for multiple other emerging commercial molecular assays, or do you think a specific EQA panel will be needed for every different cartridge or manufacturer's assays? Thank you.
Yeah, thank you for the question. And in India, at National TB Institute, we are currently developing panels for Gene Xpert EQA, and we plan to extend these panel manufacturing for TrueNat as well as for Gene Xpert Ultra as they come out. The intention is to manufacture and validate panels in such a way that they can be used across different platforms. However, these are early days to say whether it is possible or not. We will try. If not, then we are prepared to manufacture them separately for different assays. As such, when I look at it from India perspective, there are several sites. So manufacturing panels for different sites and conducting proficiency testing rounds at different times of the year should not be a challenge and can be done. Thank you.
Thank you very much. Puleng, do you have any comment on this?
Okay, thank you. So I think it will be very beneficial to have EQA panels that are compatible to run on different supplier systems. But also, I think it should also remain specific for each target. So for example, if we're talking about Gene Xpert, I think we should have HIV panels and TB panels as separate as a different process. So the procedure shouldn't differ a lot from the routine testing because we want to be specific in the targets that we are looking at in terms of quality. In South Africa, we use SmartSpot Quality, and currently they are offering HIV panels for the GeneXpert, and there's also TB, and recently they've also started producing COVID panels. So I hope that helps.
Okay, thank you very much, Puleng. We have also one question from Amy Piakek. I hope I pronounce it well, and it's addressed to Ogoamaka from Nigeria and the access concept. So the question is, can the access concept be modified for use with other rapid tests like TrueNAT?
Thanks, Ami. Yes, it sure can be used. The access concept can be actually adapted to anything because it measures the degree of fit between whatever it is you're deploying and its utilization amongst the consumer. So it can be adapted for that. We've only just done that of GeneXpert because that's what's currently being used in Nigeria for diagnosis, but it can be used for TrueNAT as well. Thank you.
Thank you very much, Ogoamaka. There is also another question that from Rupert Eneogu, and he's asking, were the findings different between high-performing and low-performing Xpert sites?
Yes, the findings were different, but then again, the findings were around two parts of the access concept. They were mainly around availability and physical accessibility, what we call physical access. So yes, while the high-performing Xpert sites, you will see that the things we called optimization package in the presentation were more available in the high-performing Xpert sites. Those same ones were lacking in the low-performing GeneXpert sites. So for instance, we talked about skewed distribution of GeneXpert facilities, and we suggested that in an optimization package, it would be interesting to have establishment of sputum referral systems. You will find that in the high-performing Xpert sites, that they have that linkage with sputum referral mechanisms that have been established so that where in facilities where the Xpert sites are broken down, they have that referral network where samples are sent to them. So that also improves their performance. So yes, there was that difference in high-performing and low-performing Xpert sites. Thank you.
Okay, thank you very much for that answer. We also have an anonymous question directed to Anita from Namibia. And the question says, how was it decided for how long and where to deploy the 4 mobile vans?
So the mobile vans was part of the survey, and the survey was over 9 months from July to August from July 2017 to March 2018. And that's why, so it was the duration of the survey that the vehicles was deployed.
Okay, thank you very much. We have sorry. Okay, thank you very much. We have another question from Nigeria, from Jemu Olainka Olabamiji, directed also to Ogoamaka. And the question is, one of the major challenges in Nigeria is the TAT for module replacement. How do we address this?
Yes, thanks so much. Indeed, it's a major challenge because Certified, which is the certified service provider for the GeneXpert modules, sometimes has some issues shipping these modules into the country. However, what we propose in the interim, so when an Xpert module is down, That is where we talk about those sputum referral mechanisms, so that the services do not actually stop because a module is down. We link to other Xpert facilities, and we're able to move the samples and get them tested in the functional Xpert site while following up with CFIDE to replace the damaged modules. Thank you.
Okay, thank you very much for that answer as well. We have a question for Rina and for Salomon by my co-chair, and the question is, setting an indigenous expert EQA systems must have many challenges, and many low and middle income countries have opted to outsource this service. So the question is, what are the top 2 challenges that other programs in low and middle income countries which are planning on setting indigenous EQA programs need to be aware of? Is the cost of those programs one of those challenges? So I would like Rina and Salomon to comment on this.
Hello, I can go fast.
Yeah. Sure.
So when you talk about the setting of the panel production in such a country with a low income, we have several challenges which varies depending with the capacity of the country, which can start from the availability of the lab, which need to have a national lab which has a P3 lab, since TB has to be manipulated within the BSL-3 to prevent the infection. So maintenance and making sure that there is a running P3 lab is very important, and that's a challenge for maintenance and other things. Then other challenges include the power interruption. So power interruption is also another key, whereby need for having stable and good capacity of the CPU and these backups is important. So that includes the budgeting of enabling that these things are available. So we have several challenges. Another one which includes the supply, which is a major challenge also. Since this production of these kind of materials need several supplies, which are mostly not available within, and they have to be imported. And every country has different kinds of mechanism whereby clearance of these things big challenges. So supply is also another major challenge in such a kind of areas. Yeah, it's in and out.
So thank you, Alberto, for the question. So I would start off by saying that in India, we have we have undertaken 3 phases, and there was expansion of implementing the CBNAT EQA program phase-wise. In the first phase, we had around 40 sites involved. Second phase, there was around 200 sites were involved. And gradually in the third phase, it was, we had included 600 sites. So based on this experience, the first thing is there are 2 different aspects to, conducting an EQA program. The first aspect is actually manufacturing the panels at a national reference laboratory like NTI, and it was manufactured here. And for the manufacturing process itself, you need to have the required consumables, the Xpert machine, and the required HR. The human resource is a major component. So, and this is as far as manufacturing of panels are concerned. The next step is how do we dispatch the panels? So the postal charges. So we had individually packaged, the PT samples were individually packaged and sent out directly to the CBNAT laboratories. So that involved the postal charges or the courier charges we had to incur. The next was actually doing the testing at the individual CBNAT site. So the trained lab technician had to be present at individual sites to undertake this exercise, and also to report the results on time through a mechanism. So we have conducted 3 rounds of the PT exercise, and gradually the sites have increased. And we have also refined the method in which the results are reported back to the PT provider. So in the 4th phase, which is currently ongoing, we have developed a EQA portal. So it's an online system. It's a software where the lab technician at the CBNet site can report his results, and we are also, as a PT provider, we are also able to track the whether the package has been received or what has happened to the package. So this being said, the cost initially, the first 3 phases, we had support from other donor organizations. However, we need to plan to undertake it under the National TB Control Program. So after the 4th phase has been completed, that we plan to cover the entire country. Beyond that, it has to be under the National TB Control Program, where it will be a budgeted activity for the consumables which is required for manufacturing, as well as for the transportation mechanism and the testing exercise at individual CBNet laboratories. Just like my colleague Solomon Bundy had alluded to, saying that the connectivity, the electricity issues at individual CBNet sites, that also we have come across in the past 3 rounds. Because of the poor internet connectivity, they could not report results, and because of the electricity issues, they could not conduct the PT test, and hence the turnaround time was extended. So these are some challenges which we have faced, and we have been able to address them better in the existing round. So thank you.
Okay, so thank you very much for that answer. And of course, we are in the times of COVID-19, and we have one question related to COVID-19. So Amy Piake asks to all presenters, so how was COVID-19 disrupted Xpert testing? Are Xpert instruments being used for COVID-19 testing? So if any of the presenters want to start answering these questions, please feel free.
In Namibia, we've tried to use Xpert for COVID testing, and we managed to do 2 sites, but the availability of the kits for Xpert testing was a challenge. So we ended up not using it in all sites that we've planned to. Thank you.
Okay, thank you very much, Anita. Dr. Rina, do you have any experience, or are you aware of COVID-19 testing in the Xpert
Yes.
Platforms?
Yes, initially in the earlier days when the pandemic, when we had the lockdowns in India, that was way back in March 2020, some of the Xpert machines which were used for TB testing were were relocated to do the COVID testing. But now, since we have the additional newer technologies like TrueNat and the other technologies coming in, the CBNet Xpert machines have been returned back to the TB program, and TB services not being affected. So that's from my end. If Dr. Tarak wants to add, he may add. So.
Yeah, in fact, COVID did affect the CBNet EQA round. Initially, when we were planning for the 4th round, it was planned for somewhere in March or April to get implemented. We had conducted sensitization orientation workshops for our national reference laboratories and intermediate reference laboratories, who would have subsequently done cascade trainings for the participating sites, and the panels would have been shipped. Now, suddenly, towards the end of March, India came to a halt, and then our panels were ready, but unfortunately, the panels do have a certain shelf life. And when we did revalidation of the panels after 2 months or so, we realized that these panels are not good, they've lost their stability, and they cannot be used. So we had to redo the manufacturing of the panels, and subsequently in August, when the things started stabilizing, the CBNet sites were back to testing for tuberculosis. We plan to implement the 4th round PAN country. So, and there too, we had some challenges in terms of how do you conduct this cascade trainings. Initially, they were always planned that at the state level, the site laboratory technicians or in charges, they would come down to the state level for a meeting in person. So with the COVID times, we adapted and we planned for doing virtual training to the extent that many of these more than 2,000 plus participants over more than 50 plus virtual trainings, they participated and these trainings were conducted.
Thank you very much. And perhaps any insights from Afghanistan or South Africa on COVID-19 disruptions on regular TB testing in Xpert platforms?
I can come in on this one. So in South Africa, we didn't have much disruption in the laboratory itself. So there were a few labs that were shut down because of staff members becoming positive, but then they were reopened later. So the big disruption that we saw was in the program as a whole. So the TB program did take a severe strain with the lockdown period and also the fact that facilities were considered to be hotspots for COVID-19. So in terms of the TB program, South Africa, on the clinical side, we started seeing decrease in number of TB samples that were coming into the laboratory.
Okay, thank you.
In Afghanistan, yes, the COVID-19 impact is also very, for in TB program, very bad. So, the big issue is our 5 Xpert machine allocated for COVID-19 testing. And also the big challenges in Afghanistan, they are allocated the MDR and reference laboratory, regional reference laboratory for the COVID-19 patient. Now our regional laboratory is not done any activity for TB, only working for the COVID-19 patient. And also the big MDR hospital is also reserved for the COVID-19 patient. Thank you.
All right, so thank you very much. I'm afraid we do not have more time for questions since we are getting to the end of this session. So on behalf of my co-chair and myself, I would like to thank you very much. I would like to thank the presenters because they show different barriers and challenges on Xpert implementation and quality control. I'm sure there are many lessons learned that can be applied in different settings. I also want to thank the audience for listening and for being engaged and asking those interesting questions. And I hope you enjoy the rest of the conference. Thank you very much.